Hello everyone, happy morning, a very good morning. I hope and I believe all of you are doing well, and I also hope and believe that I am audible and visible. Please a quick nod in the live chat if I'm audible and visible. Hi Aradhana, can you give me a quick nod whether I'm audible and visible? Hi, good morning Dr. Akash. Okay, that's great. Thank you so much. So, what the plan is in this session, this is your short images in radiology. We had part 1 yesterday, right? We had part 1 yesterday where we discussed the chest radiology, basically the respiratory system and the cardiovascular system, the most important images in radiology that we had discussed. This is part 2 today, where we are going to focus only on neuroradiology because there are quite a few images in neuroradiology that are very important. So this is dedicated for neuroradiology, and then tomorrow we will have a part 3. Okay, tomorrow we will have part 3 focusing on basically abdomen, the GIT and the genitourinary, the renal part, the OBGY part. Uske most important images is what we are going to focus tomorrow on in part 3, and then we will have part 4 which will be on musculoskeletal radiology, right? So we will have 2 more parts. This is like a quick review of all the must know images. Now what do we see here is in these sessions I have not covered the radio anatomy part, like, because that's very important part, and we will have a separate dedicated session or series on that where we will discuss only the important anatomy. In FMG exam particularly, a lot of questions are asked on radio anatomy. In the musculoskeletal radiology, neuroradiology, even in the chest radiology, everywhere a lot of questions on radio anatomy. So we will have a separate session or separate series on that. In these series I am only focusing on the pathologies, okay, the important diagnosis from the images that we need to see. So that's the plan for this session, and today 5 p.m. we are going to have KBMD, that is a live quiz, very interesting live quiz because it's hematology going on. So we will have KBMD of hematology today. Okay, so important concepts to be learned with cheat codes and mnemonics on hematology today at 5 p.m. I'll see you there. That's on the app. If you are coming for the first time for the class and you are asked for an unlock code, you can use the code Dr. Nikita Live to unlock the free live classes, right? The plus subscription is different from your free live classes in the sense that it gives you access to structured courses based on your needs, which exam you are appearing for. The syllabus would be completed of all the 19 subjects in that time duration. So we have a new batch starting today for NEET PG 2022 students and also final year MBBS students, clinical case discussion and instruments batch. It also gives you access to the question bank, and soon you will have the notes, the printed notes also coming up for the plus subscribers if you've taken a subscription of 12 months or more. An iconic subscription is Unacademy with Prep Ladder, right? FMG students, please again note down the date of your mock test, free grant test on 31st, that is the next Sunday, 10 a.m. to 1 p.m. 300 questions. You can assess your preparation there, all right? And these are the new batches that I was talking about. Whenever you are subscribing to the platform, you can use the code Dr. Nikita Live or any other code that will give you a discount on the subscription. ठीक है, चलो बताओ मुझे. This is just one question that I've put here because this is very important. The mid sagittal image of brain. First you need to tell me whether this is CT scan or this is MRI. What is this? Is this a CT or is this a MRI? Okay, so I see few students saying CT, few students saying MRI, so there's a confusion. Whenever you are confused, I mean, the trick here is you need to look for the bone cortex always, to look for whether this is CT or MR. It's the bone cortex, not the bone marrow, remember that. And what do we see here is just outside this brain parenchyma. I hope you all can appreciate this black color line, the thin black color line outside the brain parenchyma. That is the bone cortex, the inner table of the skull. So what do you see basically is, if this is the brain parenchyma, the gyri sulci that you see, just adjacent to that, that is where we have the inner table of the skull. Uske baad mein this white color which we see, that is the bone marrow, the diploic space. Why is it white? Because bone marrow contains fat. Fat is white on MR, T1 and T2. After that you will again see the black line, after that white line. So that is the outer table of the skull. So this is the outer cortex, this is the inner cortex, this is the bone marrow, and outside that the white line that you see, which tells you that this could be CT because you see the white line. Remember, this white line is not the bone here. This white line is the fat. Okay, it's the fat in the scalp which is appearing white. It is not the bone. This is outer surface. Okay, the fat, the subcutaneous fat, that is the fat in the scalp which is appearing white. So please remember, all of you, that this is MRI, because you can be asked question like identify the investigation and the labeled part. So you need to know whether this is CT or MR. We'll come to MRI sequences, but can someone tell me what MRI sequence is this? I think it got stuck. Just let's rejoin on the link. I hope this is working. Yes, please rejoin on the link. This is a T1 weighted MRI. T1 weighted MRI because the white matter, which is what is this structure here that you see? Very, very important again to identify. This is corpus callosum. So white matter is white, and the label structure here is cerebellum. This has been asked in NEET PG 2019. So that is why it's important to know this. And what is this structure here? Cerebellum. और ये pons है, ये cerebellum है, उसके बीच में ये जो triangular structure है, that is the fourth ventricle. Okay, that is the fourth ventricle. Where is the lateral ventricle? This is the lateral ventricle here, right? That's the lateral ventricle. As I said, we will have separate sessions on radio anatomy because it's important. We'll discuss that in detail later on. Now let's come to the pathologies. Some very, very important pathologies here. What happened to the video? Are you guys able to see that? Yes. Okay. So again, identify this is CT or MRI. Now this is a CT scan because here you can see that this white color is the bone cortex. Okay, this is the bone cortex that you see here. You do not see the black line surrounding the brain parenchyma. So this is a CT scan. Okay, and in the CT scan, is this the right side or is this the left side? This is the right side or this is the left side? This is the left side. This is the right side of the patient. You need to look for the side of the patient. Your right is patient's left. How is the pathology on the CT scan? It is hyperdense. Remember, in radiology, hyper matlab white, hypo matlab black, hypo matlab dark. So the pathology is hyperdense, that means it is white. Is this a contrast CT? No, this is a non-contrast. You do not see the white blood vessels. This is a non-contrast CT. You are seeing something hyperdense. Whenever you see something white or non-contrast CT, always think of two things. What are those two things that you should be thinking of? What are those two things that you should be thinking of, which is white or non-contrast CT? Either it is calcification, like the bones are white as you can see, so calcification, or acute hemorrhage. Absolutely right. Remember, it is acute hemorrhage, not chronic hemorrhage, which is white on CT. Because chronic hemorrhage, it is hypodense. The density decreases because the RBCs get lysed. Okay, so remember, In MRI, what is meant by hyperintense and hypointense? Same thing. Something which is white is hyperintense. Something which is dark compared to the normal structures, then it is hypointense. So remember, it's acute hemorrhage. So this is acute hemorrhage because this is not as white as bone. So this is left-sided acute hemorrhage. Now you need to decide what kind of hemorrhage is this. This is a EDH. Why is it EDH? Because it is idly shape, right? EDH is idly shape, that is biconvex shape. What is EDH due to? EDH is due to rupture of middle meningeal artery. It is generally associated with adjacent fracture. Does it cross the suture? No, it does not cross the sutures. Okay, it does not cross the sutures. So this is the location of the sutures. The EDH cannot go in the front, the EDH cannot go behind because it cannot cross the sutures, and that's the reason that you see that this is the skull surface. The EDH will expand like this, and that's the reason it has biconvex shape, because it cannot cross in the front or behind. So it has only horizontal direction to spread. So that is why it has this biconvex shape. Okay, yes. Remember, it can cross the midline. It cannot cross the sutures, but it can cross the midline. Opposite is for SDH. It can cross the sutures, but it cannot cross the midline. So it is the opposite one. Okay. Look at this one. What do we see here? Again, this is a CT scan, a non-contrast CT, the white bone. You do not see the white blood vessels. This is the right side. This is the left side. And we see a pathology here, which is like this: hyperdense, non-contrast CT white, hyperdense. It is acute hemorrhage, right? Always remember, it is acute hemorrhage. It is on the right side. It is SDH. Why? Because remember, SDH, S for sickle shape. Okay, SDH is sickle shape. So you can see this SR shape, and you have the concavity here, right? You have the concavity here. So it can cross the sutures, right? It's going in the front and back. It has this, it follows the brain surface. Okay, it follows the brain surface. Yes, there is this midline shift. You can see that this is the midline in between the lateral ventricles. And you can see there is midline shift to the opposite side. Why? Because this hemorrhage is causing the mass effect. It is pushing the structures to the opposite side. So there is significant midline shift. There is subfalcine herniation. Midline shift, subfalcine herniation. So we need to intervene in these cases. So there is significant midline shift also present. STH is due to rupture of cortical bridging veins, right? It's due to cortical bridging veins. Let's see the next type of hemorrhage here. What do you think is this? Is this a contrast CT or a non-contrast CT? This is a CT because the bones are white. It's a non-contrast CT because not all the sulcal spaces are showing the white thing. You see something white in this sulcal space. What is this area anatomically? This is a non-contrast CT. What happened, Rameshwar, with episode 6 of NF100? So this is the area of the Sylvian fissure. Okay, this is called as Sylvian fissure on the opposite side. You can also see the cisterns. Cisterns are the CSF containing space. This middle cerebral artery wala cistern, the perimesencephalic cistern. You can see that these are appearing white. White on non-contrast CT again is acute hemorrhage. It is white in the CSF containing spaces, that is the sulcal spaces or the cisterns. CSF containing hemorrhage is subarachnoid hemorrhage. Okay, that is subarachnoid hemorrhage. Okay, see, let me check that episode 6. I'll have a word with the team and we'll see on that. Okay. So when you have hemorrhage in the CSF containing spaces, that is subarachnoid hemorrhage, how does the patient present? Does the patient present with hemiplegia, paraplegia? How does the patient present? Worst headache of life. It is your thunderclap headache. Very, very important. So it is thunderclap headache. Okay, that is thunderclap headache. So this is subarachnoid hemorrhage that we see here. And always remember, what is the investigation of choice for acute hemorrhage? In all these hemorrhages which are seen with trauma or aneurysm rupture SAH, it is non-contrast CT. For chronic hemorrhage, what is the investigation of choice? Yes, Dr. Ravi, I'm sorry I could not provide yesterday. Today I'll definitely try to share the PDFs. Okay. Chronic hemorrhage is MRI. What sequence of MRI? Important for NEET PG INI-CT students. Either SWI or GRE. Susceptibility weighted imaging or GRE is the sequence used for chronic hemorrhage identification. Alright. Okay. Let's see the next one now. Identify the investigations first. A and B, CT or MRI. What is this? Both CT, both MR, one CT, one MR. What is this? Dr. Tamil, maybe we'll have a dedicated session on MRI sequences. I have not included the sequences here, just focusing on the pathologies. I have discussed in Plus course for sure. If you are a Plus subscriber, you can watch that radiology course as well. Yes, both are CT scan. You can see it's a white bone. It's a non-contrast CT. The sulcal spaces are not white. But in both of these, you see something white hyperdense here, something white here, something white here. This is well within the brain, surrounded by brain surrounding. So this is your intraparenchymal hemorrhage. This is within the parenchyma, intraparenchymal hemorrhage. If I ask you which of these images, A or B, do you think is because of hypertension? Which of these do you think is because of hypertension? Is it A or is it B? Gitanjali, yes, you can just search on YouTube. I've taken a session on CD markers के mnemonics previously. I'll be taking it again soon, but आप एक बार वो भी देख सकते हो before that. Yes, this is because of hypertension. Why this is because of hypertension? Because this is in the location of your basal ganglia. So putamen is a very common site. Your basal ganglia internal capsule is a common site. Okay, that is a common site. And this one is in the lobe, right? It's in the cerebrum. And this is less likely to be hypertension. It could be because of trauma, cerebral contusion, or it could be because of your AV malformation as well. So whenever you see abnormal hemorrhages at abnormal site, you should think of alternate pathologies. Okay. Let's see the next one here. Okay, so this image is to tell you the difference between ischemic pathology and hemorrhagic pathology, right? So acute stroke could be either ischemic or it could be hemorrhagic. How do we differentiate? Acute hemorrhage is white. As you can see here, this pathology, this is white. So this is hemorrhagic. This pathology which you see is not white compared to the rest of the brain parenchyma. This is dark. So this is hypodense. Okay, that is hypodense. So remember that infarct presents as a hypodensity. There is edema, there is accumulation of water which decreases the density, so it is hypodensity. While hemorrhage is a lot of fresh RBCs coming, they are dense, so it is hyperdense. So remember, ischemic is hypodense, hemorrhage is hyperdense. That is a basic concept to be understood. And here if you see, what do we see here? What is this part of the image showing? What is this, anyone? Late hemorrhage is also hypodense, Shiva. Absolutely right. But then in our clinical practice, we know that we are following up the patient. The patient comes for imaging when it's an acute hemorrhage first. And then when you are following up, you know that this is because of the hemorrhage, right? And also the infarct will follow the vascular territory. Like in this case, you see this is your MCA ka area. This is MCA infarct, very, very well defined in that territory. Okay. Prem, as I said, I'll be covering the anatomy in a separate series. Absolutely right. Very correct, Shamim. So these are the occipital horns of the lateral ventricles. And you can see something white here in the occipital horns. That is the intraventricular hemorrhage. So this hemorrhage has extended into the ventricles also. And you can see this because of the intraventricular hemorrhage. That is the dilated ventricles. Okay, those are the dilated ventricles leading to hydrocephalus. Alright. So remember, ischemic versus your hemorrhagic. Now tell me, what do you think is the diagnosis in this image? Yes, absolutely right. On the left side, you can see that there is a hypodensity. This area is more dark as compared to the rest. This is a hypodensity. Then it is your infarct. What territory? This is MCA infarct. In the middle, this is going to be MCA. This is anterior cerebral artery. This is posterior cerebral artery. So this is left sided infarct, left MCA infarct. Okay, this is left MCA infarct. Next one, this is not concavo-convex. This is within the brain parenchyma. Concavo-convex, biconvex, STH, EDH is outside the brain parenchyma. Right, this is well within the brain parenchyma. This is a left MCA infarct. What is the most sensitive investigation for infarct or ischemic stroke basically? What is the most sensitive investigation for ischemic stroke? Remember, it is diffusion weighted imaging MRI. It is DWI MRI. Okay, DWI MRI. Next one, let's see who's able to answer this first. What do you think is the sign which is shown here? What is the diagnosis? You are close, Vivek, but this is not lateral sinus. No. Very good. Archana, absolutely right. This is, yes, Anisha. Now this is a contrast enhanced CT. This is a CT scan. You can see this white blood vessels here, right? These are the blood vessels. You can see here as well. On a contrast enhanced CT, you can see in the posterior part here. So if you can see here, this is a triangle, right? This is a triangle which is white only in the borders. The inner part of the triangle is empty. What is triangle called as? Alpha, beta, gamma, delta. Triangle is basically your delta. And how is the triangle? The triangle is empty. It is not filled with contrast. So this is the empty delta sign. Anatomically, this is the location not of your lateral sinus. Lateral, as the term says, will be lateral, your sigmoid sinus. This is superior sagittal sinus. Okay, this is the superior sagittal sinus. So your superior sagittal sinus like this, when you take a cross section, you'll see is anteriorly, you see it posteriorly. So basically on a contrast scan, any vessel not filling with contrast tells you it is a thrombosis. So this is superior sagittal sinus thrombosis. How does the patient present of venous sinus thrombosis, the dural venous sinus thrombosis? Okay, Dr. Avi, if you had an image in FMG showing half black and half white SDH, if the image was like this, so this part is white and this part is black, basically this is your acute on chronic SDH. So pehle dark wala is the chronic SDH and you have the acute SDH in that. Okay, so it's acute on chronic basically. So this is the patient presents with. How does the patient present with? The patient presents with headache and seizures. Remember this important history. Headache and seizures is the history with venous sinus thrombosis, predisposing risk factors. In children, dehydration, basically hypercoagulability state, dehydration, OC pills. Okay, these are the important, or infection, sepsis are the important predisposing factors for venous sinus thrombosis. All right. Let's see these images. These are very, very important. Basically your neurocutaneous syndromes. Okay, the neurocutaneous syndromes. First one, very, very important. What image do you think is this? What is the first image showing? So this is the CT scan. As you can see, the white bone tells you that this is a CT scan. These are the lateral ventricles, and along the ventricles you can see those white calcified nodules. Why do I call it calcified? Because there is it is white like bone, right? It's white like bone. So this is along the ventricle lining, that is ependyma, subependymal calcified nodules like you see here, or the hallmark of tuberous sclerosis. Subependymal nodules, some of which can be calcified, are a hallmark of tuberous sclerosis, also called as epiloia. Patient presents with epilepsy, low IQ and adenoma sebaceum. Very, very important. You have ash leaf macules, right? You have Keenan tumor, periungual fibromas, you have Chagreen patch. All these are important features of tuberous sclerosis. Very important again, what do we see in this image here? What is this image showing? So anatomically, this is the region of the pons. This is the region of the cerebellum. And we see that in the cerebellopontine angle, there is a lesion which has this ice cream cone appearance. This is the cone, this is the ice cream scoop. So this is the area of the 7th, 8th nerve, the internal auditory meatus. Coming out from there is this lesion which is schwannoma, the 8th nerve, vestibular schwannoma. So remember, ice cream cone appearance, that is vestibular schwannoma. And if you see bilateral vestibular schwannoma, then in that case, what is the diagnosis? Whenever you see bilateral vestibular schwannoma, straight ahead you diagnose the patient as NF2. Remember, bilateral is 2, it is neurofibromatosis 2. Here in this case, what do we see in the cerebellar lesion? There is a cystic lesion. Only this part is enhancing. Along the wall, the nodule is enhancing. So we have a cystic lesion with enhancing mural nodule. You can see the enhancement is only along that nodule, and this is hemangioblastoma. The differential could be pilocytic astrocytoma, and hemangioblastoma is associated with which syndrome? Which neurocutaneous syndrome? VHL. We discussed in the yesterday's special class. VHL, von Hippel-Lindau syndrome, right? VHL has hemangioblastomas. Very, very important. And what do we see in the last image? What do we see in the last image here? In the X-ray skull, this white is the calcification following the gyri called as the tram track calcification. In the CT scan, this is the white calcification here, again following the gyri called as tram track calcification. So tram track calcification is a feature of Sturge-Weber syndrome. Very, very important. Tram track calcification, Sturge-Weber syndrome. And in Sturge-Weber syndrome, what history do we have in Sturge-Weber syndrome? Port wine stain. A patient with port wine stain on the face along with seizures. That is the classical history that is given in Sturge-Weber syndrome. So remember, Sturge-Weber has a stain. Sturge-Weber has seizures. So stain with seizures is Sturge-Weber syndrome, SSS. Alright. Next one, identify these images. What do you think is the diagnosis in these images? Amazing. Absolutely right, Bhagraj and Bebek. Yes. This is neurocysticercosis. First look at this image. This is the CT scan. You can see all these white lesions which are there. White lesions are calcified lesions. The multiple white lesions, they give like the starry sky appearance. Okay, this is the starry sky appearance, and which is seen with neurocysticercosis. We know that in the final stage, the calcification happens. When there is calcification, we know that it is healed, it is old, and we do not need to give anti-epileptics. We just need to give anti-epileptics. We do not need to give your acute parasite wala albendazole वगैरह देने की जरूरत नहीं है, because tinea solium is dead when it is calcified, right? So no need of giving anti-parasitic. So this is the starry sky appearance. You can see the multiple calcified lesions. Here, what tells us that this is a neurocysticercosis? Because you can see the lesions are black, they are dark like CSF, and within the lesions you can see the white dot. So here in this images, dark like CSF, and the dot represents the scolex of tinea solium. So this is a cyst with a scolex, that is neurocyst, and sarcosis, the scolex. So neurocysticercosis. Okay, this is neurocysticercosis. All right. What do you think? Which infection is this? Very, very important. Which infection is this? Yes, Dr. Damal, in MR spectroscopy, in neurocysticercosis, we get multiple amino acids peak. Why do you call this as toxoplasma? I see majority of you answering as toxo. Why do you call it toxo? It's not toxo. It is the most common infection that we see in our country. What do we see here? This is post-gadolinium. It's a contrast MRI. This lesion which you see here, it's a necrotic lesion. Only peripheral enhancement is seen. Central is non-enhancing. It's a conglomerate lesion. And all this which you see in the sulcal spaces, like you see here, this is like the dirty enhancement that we are seeing, the thick enhancement along the meninges. Meninges enhancement, that is meningitis. And this is a conglomerate lesion that we are seeing. So when you see conglomerate lesion with meningitis, you think of tuberculosis. Okay, so conglomerate lesion with meningitis. You can also see hydrocephalus here, right? You can see the dilated ventricles. So meningitis we know can lead to hydrocephalus, communicating type. All this is your TB. And the question is, in MR spectroscopy, what peak would be seen? Remember, TB, mycobacteria, has lipid in its wall, mycolipid. So you have the lipid peak. Okay, lipid peak is seen on MR spectroscopy. Okay, lipid peak is seen. Alright, let's go to the next one. What do you think is this infection now? A patient with fever and altered sensorium. This is what you see. What do you think is this infection? Very good. A.V. Soni, absolutely right. This is herpes encephalitis, HSV encephalitis. Why is this HSV encephalitis? Because remember, it has a tendency, an affinity for the temporal lobe. Okay, whenever you see temporal lobe involvement, right, this is the temporal lobe, this is the midbrain. So uske baaju mein lower most you see this altered signal intensity, the hyper intensity in the temporal lobe. Always, always, always think of herpes encephalitis. What would be the treatment? For herpes encephalitis, we give acyclovir, right? Acyclovir needs to be given. What is the risk with acyclovir? It can be nephrotoxic. So you need to check serum creatinine also before and during when you are giving acyclovir. Remember, it is nephrotoxic. Okay, so this is HSV encephalitis. Next one, what do you think is this infection? What is the diagnosis here? Very, very important. Okay, this is very, very important and frequently asked. Even in NEET PG 2021, there were related questions. Yes. First, identify whether this is CT or MRI. Whether this is CT or MRI, what is this? This is a MRI. Okay, this is a MRI that we are seeing here. So in this MRI, what are we seeing? Why this is MRI? Because the bone cortex, okay, this is the vertebra, look at the cortex, okay, look at the cortex is black, so this is MRI. And in this MRI, you can see that this area is abnormal. This vertebra is showing abnormal signal, this vertebra is showing abnormal signal. And if you see here carefully, this is the vertebra, posterior element, vertebra, uska posterior element, vertebra, posterior element. This is the vertebra with posterior element here, vertebra with posterior element. यहाँ पे भी एक posterior element है. That means there is one vertebra here which is collapsed, significantly collapsed. We are not seeing the vertebra. So you can see that the vertebra is collapsed, the intervertebral disc is gone. Whenever you see this intervertebral disc gone, always think of, at least in our country, start thinking of TB. Because in other pathologies like metastasis, multiple myeloma, the intervertebral disc is normal. They involve the vertebra, they do not involve the disc. While in TB, the most common type is the paradiscal type. It involves the intervertebral disc. So involvement of two vertebrae with the intervertebral disc gone, always think of tuberculosis, that is the pot spine. Okay, always think of pot spine. And pot spine can lead to abscess in the psoas as well, right? So question asked in NEET PG, psoas abscess. Okay, it can lead to psoas abscess. Next one, what do you think is this? You can see this eye of tiger. This is the eye of tiger appearance here on MRI. So just remember these important signs. Now we are looking at some important signs in neuroradiology. Eye of tiger sign. You can remember as tiger is very Dharavna, scary animal like a Halloween. Halloween is your Hallerwarden. Okay, so eye of tiger sign is seen in Hallerwarden Spatz disease. Halloween is Hallerwarden Spatz disease, which is also called as PCAN, pantothenate kinase associated neurodegeneration. So eye of tiger sign is seen in Hallerwarden Spatz disease. Next one, what sign do you see in this image? So staring at you, there is something which you can see. What sign is that? Absolutely right. So in this midbrain area, you can see some face here. These are the ears, these are the eyes, you have the nose and you have the mouth, right? So that is face of giant panda. Okay, that is the face of giant panda sign. And yesterday we have discussed in the special class fast 5 MCQs, who has a face like giant panda? Wilson has a face like giant panda. So it is Wilson's disease. Gene affected ATP7B, not 7A, chromosome number 13. It is autosomal recessive. Basal ganglia can be involved. What do we use in the treatment we have read? Zinc or trientine. Okay, those are the drugs used for Wilson's. All right. So face of giant panda, remember Wilson. Next one, what sign do you see here? Very good, Vivek. Absolutely right. What do we see here is, look at the frontal horns of the lateral ventricles. They are prominent as the posterior horns. Normally the frontal horns are pinched. They are very, very small. Okay, they are very small. Here the frontal horns are dilated. So when you see the frontal horns, the front cars, the wheels of the car dilated as much as the back wheels, this is called as boxcar appearance. This is boxcar ventricles. Boxcar is seen with Huntington's disease. We have seen this in trinucleotide repeat disorders. Why do you get the boxcar ventricle in Huntington's? Because Huntington's is chorea. Chorea is C for caudate. So caudate atrophy. So when you get the caudate, which is adjacent to the frontal horn, that is atrophied. So the frontal horns get space to dilate. So that is why the frontal horns dilate. So you get boxcar ventricle. The trinucleotide repeat is CAG. What was the clinical manifestations? The 3M. How does the patient present? Movement abnormality, mood abnormality, and memory abnormality, that is dementia. So movement, mood, memory. Yes, there is anticipation in the future generations. It comes as an earlier age. So that is Huntington's disease. Okay, remember Huntington's chorea, caudate affected. So frontal horns dilated. You get the boxcar ventricle. Next one, can someone make a diagnosis here? Let's see who can make a diagnosis in this image. I'll tell you where is the pathology. This is the area which is abnormal. This is the area which is abnormal. Let's see who gets this right. What do you think is the diagnosis in this case? Amazing, Prashant. Absolutely right, Prashant. Absolutely right. Yes, AV Sony. This is craniopharyngioma. Yes, Anisha. This is craniopharyngioma. Very, very important and a frequently asked question. Craniopharyngioma, it's a predominantly suprasellar lesion above the pituitary. That means in the midline you will see, like you are seeing here in the midline. It is a cystic lesion with calcification. Calcification if present in a sellar suprasellar lesion. C for C. Remember, it's craniopharyngioma. How does the patient present? It has bimodal distribution. It is generally in a child, and the patient has headache. Very, very important, the patient has visual complaints as well. Why? Because pituitary ke upar optic chiasma getting affected. NEET PG 2021 question. What visual field defects the patient will present with? Optic chiasma getting affected. That is bitemporal hemianopia. FMG students, please remember this, very, very important. Bitemporal hemianopia is what is seen with pituitary lesions. Very, very important. So this is the cystic component, the dark color, and this is the calcification component, white color. Whenever you see calcification, midline lesion, sellar, suprasellar location, that is craniopharyngioma. So again, see here midline lesion with calcification, think of craniopharyngioma. Look at this MRI image, the contrast MRI image. This is the pituitary gland. This is the stalk of the pituitary, and we see here a suprasellar lesion. Okay, so predominant it has suprasellar component. Why this is not pituitary adenoma, Bhagraj? Yes, we are coming to that. Why will this not be a pituitary adenoma? Because pituitary adenoma grows from the pituitary. So it will cause the pituitary fossa enlargement. The sella widening would be seen, right? So the thing is, if this is the pituitary fossa, the adenoma is within it. It could be small, microadenoma, or it could be large. So it will cause the sella enlargement, and then it can go upper in the suprasellar component. It gives the figure of 8 appearance. Okay, it gives the figure of 8. While craniopharyngioma predominantly is suprasellar. It comes from upper se niche, while adenoma is from niche se upper. Okay, so that is how you differentiate. If there is sella widening given, then it's definitely adenoma. Otherwise, craniopharyngioma is suprasellar. Okay, that is how we differentiate. Next one, very, very important. Look at the images and what do you think is the diagnosis here? Very good, Nirbhay. That is the vein of Galen malformation. Okay, that is the vein of Galen malformation. Classical image. You will get the mid-sagittal image. You will see the dilated vascular structure like this in the mid-sagittal image. How does the patient present? Vein of Galen malformation is a AV fistula, like you see here. Not with the vein of Galen, the precursor of it, the prosencephalic vein. Usme there is this AV fistula. So AV fistula affects the heart. The neonate presents with heart failure because it's in the brain. There is hydrocephalus. So remember, whenever you get this classical history, a newborn, a neonate with heart failure and hydrocephalus, it's always a vein of Galen malformation. This is the AV fistula here. This is in the MRI showing the prominent vessel here, these prominent flow voids, and on the CT scan this is the enhancing. Because it's a vascular malformation, it will enhance with contrast. So this is the classical image of vein of Galen malformation asked in one of the NEET PG exams. Yes, it is high output cardiac failure and hydrocephalus. Very, very classical. Again, a very important image here. What do you think is the diagnosis in this one? Very good. This is multiple sclerosis because you see the Dawson's fingers here. Okay, multiple sclerosis, Dawson's fingers. Is this a CT or MRI? This is a MRI. You can see this black line here adjacent to brain parenchyma. This is MRI. What sequence of MRI? Water is black, so it's not T2. White matter is black. White matter black, water black, all black is flare. So flare sagittal image, you see these white areas like the fingers projecting, that is the Dawson's fingers, which actually represent the demyelinating plaques. Okay, they actually represent the demyelinating plaques. So this is multiple sclerosis. And what is the investigation of choice for multiple sclerosis? CT or MR, non-contrast or contrast? What is the investigation of choice for multiple sclerosis? The investigation of choice is MRI with contrast. Okay, remember it is MRI with contrast. Why do you want to do with contrast? So that you can look at the enhancement of the plaques. If the plaques are enhancing, that means they are acute, the recent plaques. If the plaques are not enhancing, that means they are old. So that helps you to identify dissemination in time. That means they are new and old together. According to the criteria, what criteria we use? McDonald criteria. There has to be dissemination in time, dissemination in space. So we need a contrast scan. Okay, we need a contrast scan. Next one, coming to two brain tumors, very important. The last two images in neuroradiology. What do you think is the diagnosis here? So this is a MRI, a contrast enhanced MRI. We see a very well defined lesion here. Tell me, what do you think? Is this tumor, is this mass within the brain parenchyma or is it outside the brain parenchyma? Is it intraaxial or is it extraaxial? What do you think is this tumor? Is it intraaxial or extraaxial? This is outside. Yes, this is extraaxial lesion. You can see the brain surface is here. Okay, you can see a CSF cleft. CSF is black here. You can see surrounding the tumor. The brain is compressed. This is extraaxial. If it was intraaxial, within the brain, it will be surrounded by brain throughout, right? So this is the extraaxial lesion. You can see this tail-like enhancement from the lesion. That is called as dural tail sign. And remember, where is this dural tail sign seen? Dura is meninges. So it is seen in meningioma. Okay, this is seen in meningioma. Remember the clinical presentation. Generally, it's a female patient. Why female? Because it has progesterone receptor positive. Female patient, many times incidentally diagnosed. Sometimes it can cause headache. You have very intensely enhancing lesion, vivid enhancement. Okay, it's an enhancing lesion with calcification also might be present, and it shows the dural tail sign. Okay, that is meningioma. What do you see in histopath? How will you identify that this is meningioma? There are psammoma bodies present, right? It has psammoma bodies. The world appearance is the terminology given. World appearance psammoma bodies are seen in meningioma. Okay, very important. Next one, what do you think is the diagnosis in this case? Yes, that was MRI Aishwarya. This image, if you are asking, you can see the black color surrounding the brain. This is a MRI, a contrast MRI. Okay, this is a contrast MRI. Very good. This is glioblastoma multiforme, the GBM. Which is your grade 4, very aggressive tumor. And why do I call it GBM? Basically, it has this butterfly shape. You can see it is crossing the midline. It's on both sides of the midline. That means it is involving the corpus callosum, right? It involves the corpus callosum, crosses the midline. That is a GBM. And you can see this necrotic areas. GBM has necrotic areas which indicates high grade malignancy. So these are the non-enhancing necrotic areas, and this is butterfly shape, right? You have the butterfly shape appearance. So that is GBM, very aggressive tumor. On MR spectroscopy, what peak will we see? On MR spectroscopy, brain tumors intraaxial, they give choline peak. Okay, on MR spectroscopy we will see the choline peak. Okay, so that is that is about neuroradiology, I think. So we have covered almost everything, the very important images in neuroradiology in a very short time. Please revise this. I'll be sharing the PDF with the annotations, whatever I have written on the images, and I'll share without annotations as well for you if possible, so that you can revise this. Alright, so let me do it right away because I tend to forget in the rest of the day. And let's meet again at 5 p.m. Right, we are meeting at 5 p.m. on the app like we do every day. Today we have KBMD, a live quiz on hematology. Okay, it's a free live class. If asked for a code to join the class, you can use the code Dr Nikita Live. Okay, use the code Dr Nikita Live. Okay. In Telegram group, PDF of previous few sessions are missing. Yes, in the next one day they will not be missing, they will be there. है ना? चलो मैं अभी शेयर कर देती हूँ इसका PDF on the group, then only I'll go out of this room. Otherwise, yes, it gets pending. So I'll do it right away. Okay. So thank you so much everyone for joining in this morning session. That's a great start of the day. Have a very productive day today, and keep studying, keep revising, and keep winning. See you at 5 p.m. We will have the next part of short images radiology part 3 tomorrow 8:15 a.m. where we will discuss GIT and GUT images. Okay, we will have GIT, GUT tomorrow, and then we will have part 4 where we will discuss musculoskeletal radiology. Okay, the MSK radiology. All right. Thank you and goodbye.